Hi everyone and welcome to EXTime Conference 2026. My name is Svet and I'm design lead at TechMagic and the host of UXTime Conference. This year's conference is dedicated to healthtech domain and the role UX plays in creating better healthtech experience. We will begin in just 1 minute, right after a few words from our amazing partners. Have a great time.
Hello, and welcome to UX Conference 2026. My name is Alexander, and I'm a delivery director here at TechMagic. Just a couple of words before we begin the official part. TechMagic was founded as a company in 2014 by 3 founders. Initially, at its core, we started as a JavaScript company. Now, we have in our portfolio many other technology stacks, including Salesforce, .NET, C++, C Sharp, React Native, you name it. We're actively growing our community and exploring different other technology stacks as well, starting from AI, agentic workflows, and always evolving and growing our business. We have customers from the States, Australia, Canada, and have experience working with enterprise customers and even small startups that are just trying to raise some funds to build their new great innovative idea. So if you have somebody who might need some help with their design or even some development, don't hesitate. Feel free to reach out to us. Have a great conference.
Good morning, everyone. Good afternoon. I would like to begin with the simple question. Who do we imagine when we designing a healthcare services? We may imagine someone who is calm, confident, digitally skilled, able to see and hear, comfortable with the medical language, using a modern devices, and connected to reliable internet. That person might exist, but they are not only the person who needs healthcare. Very often, they are not even the person who needs it most urgent. Healthcare services are becoming increasingly digitally. We book appointment online, complete forms, review test results, download even the medical documents, manage prescription, verify our identity using the video consultation, and make important decisions through screens. Digital services can make healthcare faster and more convenient. But when those services are designed around a narrow idea of the users, they can create new barriers for those people who already face the greatest difficult access care. Today, I just want to little bit explore how the gaps in research and testing become a real healthcare barriers, why these gaps are often invisible to the product teams, and what we can do to design services that work for real people in the real situation. The central message is this: when do we do te- we when we don't test with the people, most likely they face barriers. We do not remove those barriers. We simply move them in the real world. So I would state that the healthcare is there's not normal digital journey. So healthcare, I would say it's different from the many other digital experience. If you cannot buy a pair of shoes online, yeah, I may be frustrated. I can try to go to different store, I can another device, another day. If you cannot access the healthcare services, this consequence may be much more serious. A patient might trying to book an urgent appointment when in pain. Imagine the situation. You want to go to the doctor and you really have a high fever. So what do you do? Or you need a complaint form for the child late in the superlight. Or the older adult may be reading the test results fine with the unfamiliar language. Even today, I will show you the result of the accessibility for my test result, which were sent in the PDF. A person using a screen readers may be trying to enter a security code before the session expire and other different situation. In this situation, the user is not necessarily calm, focused, or confident. They may be anxious, tired, afraid, distracted, or worry about them making a mistakes. They may be using their old phone, a shared device, unstable internet, or very low internet. I don't know if you know, but in Poland, approximately 10% population still don't have access to the high internet that it's able to, read the prescriptions, etc. This change, how should evaluate the service? We cannot look only at whatever the task is technically possible. We need to understand the context in which the task is performed, the emotion stated of the persons, the consequences of failure, and the support they may or may not have available. A healthcare is not simple as sequence screens. It's often high stakes of the person life. So who is missing the from our research? Many teams conduct the user research, usability testings, and so on, or custom interviews. The problem is not always that research is missing. I would say the problem is that the same kind of the people are often missing from the research. Older adults are frequently represented. On the latest research that I was observer, there was no any person 60 plus because they mentioned, oh, there's not our group. We are not interested in. So this is quite important when we are doing the research. People with disabilities may be also excluded because there are teams are not sure about how to recruit them, how to treat them, how to make a session accessible, and how to accommodate additional support needed. People who are using assistive technology are sometimes treated as the specialist accessibility group rather than ordinary healthcare user. Yet, screen readers, magnification, voice control, switch devices, caption, keyboard navigation. There is a simple ways that people access digital services. We often may miss the people with the low literacy, limited digital confidence, the people with the cognitive disabilities, learning disabilities, non-native speakers, and people who are using the older devices and so on. So the group is really, really group one. Also, we need to take into account that temporary and situational impairment. A person might have a broken arm, migraine, and other perspective that in this moment you need a medical emergency. This condition may not be a permanent, but they directly affect whatever a service is usable. When these people are absent from the research, their needs do not disappear. The team simply loses the opportunity to see the barriers before the service is released. So it's quite important to invite the different kind of the people on the research. So how the research usually become the healthcare barriers. The path from research gaps are real barriers is often surprisingly short. First, a group is missing from the research. Perhaps the team tested only with the confident digital users. Perhaps all participants use the smartphones. Perhaps nobody uses screen readers. Keyboard navigation, the voice control. Oh, this is very important, the voice control. How you can interfere with the interface. High zoom or low bandwidth connection. It's also important. Sometimes we need to have emergency requests in the places that we don't have access to the good internet, like, for example, the mountains. So this is quite important to take in consideration. Second, the teams make decision based on the incomplete evidence. So assumption. The forms appears clear, the authentication process seems straightforward, the PDF looks readable. Even I mentioned about the PDF because that is like fan. I received the really lovely design from the PDF, but when I tried to use the screen reader. So screen reader is a tool to read loudly what is on the screen. There's nothing. So it looks colorful for me. Maybe the language used in this document is fine, but the people that are blind, they are not able to read this information. Third, the decision become part of the live service. No one intends to exclude anybody, but the design still reflects the ability, devices, and language, and the confidence of the narrow groups. So finally, the barriers appears in the real world. Someone cannot book the appointment. Someone cannot read a PDF document. Someone cannot upload a referral, and so on and so on. Someone gives a cold snap, misses a deadline, delays treatment, or depends on another person for tasks that they should be able to complete privately and independently. So the problem is not only the interface is difficult, the problem is that the healthcare outcome may now depends on the whatever the person can overcome and barrier the team never observe. So small issues is when I would say small issues are not small. In the healthcare, details that appear small during the design review can be a really big one. So let's consider a form error message, invalid input. Okay, so I can try to read again the label and try to somehow fix it. But imagine this the same error that appears for the blind person or the person who having the same cognitive or different cognitive perspective. So what I did wrong, how to fix it. So if you're using this on the regular request on appointment or renew the prescription, it might be block the access to the service. How we can fix it? Instead of invalid input, please put your first name. Put your phone number with prefix. So this is a small thing that you can really change the way how we perceive the perspective. Or the consider a button with unclear accessible name. We already mentioned about the PDF documents, so it might be perfect. You can just scan like file, and you just send this for the people who cannot read those information, missing headings, missing a proper semantic for the PDF. I'm usually seeing that when we're building the digital ecosystem that everything is brilliant, beautiful, but we were forgetting about the digital documents that are really important in the entire process. Authentication. It's another common example. CAPTCHA or time-limited code, inaccessible data picker, confused two-factor authentication. Those factors may be impossible or significantly harder for someone using the assistive technology, someone with the low vision or with the cognitive fudge. So imagine, you just need to please select two cars, and somebody, okay, so which one is a car? Or select this in animal. So important point is that the barrier is not just the component. The barrier in the healthcare task that is the component prevent. And this example of the PDF. So there's real one, which I received like 2 weeks ago. And you can see on the left side, you having the result from the Adobe PDF. And there is more than 20 different kind of the issues. There is no alternative text. There is no correctly defined table. On another tool, exactly the same documents, we even have a much more issues. So there's a 94 errors for one single page. One single page. So some people, without asking, somebody else cannot perform or read the information from that. It's quite crucial. So the cause of the designing from the assumption. So one of the most persistent pattern for digital product works is the assumption for the ideal user. Personally, I don't like the personas because usually we're creating the persona based on the assumption. So when I'm seeing the teams that they're designing the ideal user, oh, it's a calm, it's understand the language. They know very well digital services. They're having a good vision, good motor control, enough time, enough attention, a modern device, something that I just recently bought from the store, and reliable internet. So they can recover quickly when something goes wrong. And the healthcare often gives an opposite situation. Real users are in the pain. It might be distracted. It may be embarrassed or afraid. They usually might not understand the medical terminology. They may be using the assistive technology. They may supporting a parent, child, the partner. So that might be completing the task in the hospital corridor. Even like yesterday, I had a situation that I put some big form for my child in the corridor without a single place to sit, and I need to fulfill something. So imagine the same exercise for somebody who cannot hold a pen. So what do you do then? So teams rely intent to design only for the ideal user. So the problem is that assumptions feel inefficient. To help project to move quickly, we need to reduce apparently the complexity of the problem, but in the healthcare assumptions are not neutral. They decide which risks become visible, which risks remain hidden until a real person encounters them. When we say that most user will understand this, we should ask who is included in the most, who is excluded, and what happens to the people who cannot continue. So inclusive research does not have a perfect to be useful. And inclusive research can be sounds expensive for some team. Oh, we're still having a limited budget. We still have even the budget for the research, complex or even the difficult for organization. So from my point, as the result, some teams is postponed until they have a more time, more budget, or the perfect recruitment process. But in the practice, waiting for perfect condition often means that inclusion never happens. This is so true. So inclusive research does not have to be perfect to be valuable. The goal is not to create a statistically representative sample of every design decision. The goal is to reduce a risk by gathering better evidence from the people who are more likely to experience barriers. Starts with the most important healthcare task. Can person find the correct services? Can they book, change, and cancel appointment? Can they understand they needs to go to next? Can they complete identity verification? Can I access documents and so on, so on? The record more intentionally include assistive technology users. And I would say people with the disability, they are people, and they are very likely if you ask them, hey, hello, we're doing the research or something, could you be a part of this? They are usually super excited about it, that somebody wants to take in account their thoughts, their feelings, and also the way how they using the digital ecosystem. Remember about the older people. In the Europe especially, we are older and older. Only in Poland currently there is a 25% population is the 60 plus. Also try to find the people with the cognitive and sensor disability. Find the people using the older devices. I know that usually the organization is saying, oh, we're just only supporting um, the new devices. But maybe take in account that not everyone uses the same. Because all of us, we can just open the browser and we can also preview the page, but the same page on the older device might behave in slightly different way. Research sessions should be also adapted. Allow participants to use their own assistive technology and prefer devices. I've seen so many usability sessions that somebody came, oh, there is our phone, Android or iOS, it's a pre-configure, and the other person say, ooh, but I'm usually using a little bit of Zoom or my font size is a little bit bigger. I know that might be a little bit challenging to adapt your solution on the different devices, but try it, test it. So, and try to be a part of this real environment. When you're building the research, also use plain language instruction because you don't know with whom you met in the end of the day. Sometimes also plan to add additional time. In the case that you invite the people with disability, include the support with the person when appropriate. And don't be scared about the people who coming on the session with the dog. Try to really, really accommodate this. And most important, don't treat the slower task in completion as the failure of the participant. It might be essential evidence about the design. Even a small number of the session with the people that are usually overlooked can reveal the problems that standard testing will never show. And try it. So I would say that direct research with diverse participants is essential, but it's not only one source of the evidence. Support requests, complaints, abandoned forms, repeated errors, fail research, common question that can reveal people are struggling, and really the analytics. I can surprise that so as many people they having the access to the analytics, but they're not using those. So even the small signal that sent back that don't use the form or don't click on something that we design might be super interested, like group devices, context, when something not happen might be crucial. I would say the accessibility audits, when we're doing it's applying for the existing solution, might be really nice, important layers to identify barriers like the missing labels, incorrect focus, poor keyboard support, insufficient contrast, or inaccessible documents with and other problems with the assistive technology compatibility. So, however, the audits and usability research answer the different questions. Audit can ask the question and tell whatever a control has an accessibility name. Research can tell us whatever the name makes sense for the person. Audit can tell whatever a form is the keyboard accessible, but research can tell whatever the person understand the question, trust the process, and know how to recover from the errors. So the strongest approach combines the accessibility evaluation, usability research, and content review, analytics, and support evidence. Together, they provide a more realistic picture whatever people can complete the healthcare journey. So accessibility standards and legal requirements are essential. We need the WCAG, procurement requirement, design system guidelines, testing procedure, and technical acceptance criteria. Without them, of course, many barriers would never be identified or fixed. But compliance is not the starting point, not the final destination. A page can meet many technical requirements and still fail the user. A form can have label and still be confusing. A PDF can be tagged and still be difficult to understand. A button can have a really accessible name, but in the end of the day, your father or grandfather can really miss the context and understand what happened after we clicking on this element. So the question shouldn't we only be, does this meet the requirement? I would say we should ask the question, can the person safely and independently complete the task? I would say this is quite important. So safely, because usually those people might ask the other people, but the question is, do we really want to invite other people in this very sensitive area of our perspective? So in healthcare, accessibility, usability, content clarity, error recovery, privacy, trust, and safety are deeply connected. They should be not managed as the separate task or checklist owned by different teams. Or if they owned by different teams, they should be a together effort that this form part of service quality and risk management, that we are managed to build a better ecosystem for tomorrow. So some practical recommendations for the teams. First of all, recruit right people. If everyone in the study is digitally confident, the findings mainly describe digital confident users. So try to really diverse this people. Secondly, I would say test critical journey. Usually we focus on the happy path, but also start to do something opposite. Let's test it at these edge cases. So how do people react when they will be a failure, something happen, and when the important decision is made? Include assistive technology and keyboard users. So I would say this is a must-have. Invite the person who using the screen readers. Invite the person who using the voice control. This is not the magic technology that doesn't exist. It exists. There's people around us who are using the voice control to navigate over the screens. Also invite the people who are using only keyboard. So they are not happy user that, oh, I'm using the mouse and I'm happy. I'm using a different devices to conduct some elements. Verify the simplified content. I know that there's a way to verify if the content is right in the simple, plain language. But focus, for example, and the people who are not hearing, I would say there is really great group of the folks that you can perhaps verify as a quite important step. So how the language, if they really understand this, because if somebody is not hearing from the child, they usually having a very limited words and the sentences that can use it. And that group of people might be great to just adjust. If the language is clear and it's everything is understand and the people feel okay after they conduct this perspective. Also test the forms, errors, and how the people recover for that. I'm seeing that we tend to forget about it. There's like only happy path. So it is important to have this edge case to verify where we are. And the most important, that don't forget about the end of the services. So usually there's some digital documents will say, oh, yes, Mr. Piotr, we will just send this on your email mailbox. And I just received a PDF, which is completely inconsistent, it's not accessible for the screen readers and so on. So it's important to take this journey in the end, and don't forget about this, a very important perspective when we're doing the evaluation. So a little bit how to plan the research plan. Simple approach can help teams begin immediately. Before research starts, define the critical task and people most likely to face the barriers. For the appointment service, this may include older adults, screen readers. I know that I repeat this over and over, but it's important that you come back and start to act on your product. During the recruitment, of course, try to verify the participants that profile high-risk situation. And remember, you don't need to solve every representation gap in the single study. Beginning by making the sample less narrow and matching recruitment to the risk of the services. And I would say the most important is to start. If you even invite the first person on the beginning, that will be, I would say, the best. During the session, of course, you can try to be trained how the people using the assistive technology. But I would say usually the user researcher are those people who are not scared about the failure. You can, of course, spend this time with older people, people who are blind, people who are not hearing. A little bit earlier to ask guys, okay, how should I behave during the session? How should I help you? And of course, you can just analyze this perspective, how we should act. And don't be, if even do something wrong, still you can improve. This is our beauty as the humans. So during the analyze, describe the nature and impact on this issue. So it is accessibility defect or usability problem or the content issue or trust concern or the safety problem. This should be usually defined as the separate task. And of course, if you have a quite big team, each team should receive those tasks after the user research. And of course, after lunch, continue learning. So user research is not only applying for the healthcare, but is also applying for all services that we are building. You still supporting, you analyzing the FATE task. You also verify the compliance. I remember one day that I was invited to the big factory, and I spent time one day on the line, and I spent another day on the service desk. And that was really amazing adventure because I learned during those 2 days much more about the process and about the people who complain. Because usually, when we calling the support, we complaining that it's a fruitful. Even you should have put the project manager on the everyday perspective. So a little bit of closing. So I would like to close with the human side of this topic. So when people cannot use a healthcare services, the system often treats the difficulty as their problem. They are told to call somebody, ask family member, try another browser, return later, or print the document or visit the person. So I know that the technology is helping, but we need to realize that those barriers were designed, reviewed, approved, and released before the person even arrived. So we designed those barriers. So inclusive design in the healthcare is not only about the ability, it's all about the compliance. It's about whatever people can access care, understand information, make informed decision, and protect their privacy and maintain their independence. So it's also about the trust. The services will explain what is required, protect the information, support them where something goes wrong, and not exclude them because they use the system differently. We will never represent every possible user and every possible situation in every study. We are only humans, but we can stop treating narrow research as complete evidence. We can look deliberately for missing perspective. We can test the journey when failures has the greatest consequences, and we can make the risk visible before they reach patient. So when we do not test with the people most likely to face barriers, we do not remove those barriers. We simply move them into a real world. So I would say our responsibility is to find those barriers earlier, where we still have the opportunity to change the design. And I would say this is a perspective that I would like to leave you. And don't miss the user groups in the research, which can be real barriers for the healthcare access. Healthcare users might be stressed. They may be tired. They may be in pain, or maybe they are unfamiliar with the system, or they're using assistive technology. Accessibility, usability, content must consider together. And remember, inclusive research can be begin with the small steps. Intentional change, even for the recruitment, start from the one person and then more and more. And maybe in the end of the day, you would just invite and you or designed the study for the blind people only to know their perspective. So thank you for this opportunity. And remember, designing for the real people in the real situation, it's not for the idealizing the average user. It's not this case. So I wish you all best. Think about accessibility and take the small steps. Thank you.
Hello, everyone. Thank you to the UX Time team for having me. My name is Natalia Elizondo. I'm a senior product designer at Teladoc Health, and I recently led a team of 3 to 4 designers to develop the UI, UX, and sound journeys of a Class 2 medical device in just 1 month. The device was a smart weight scale, and prior to this project, most of my team had only worked on app and web design. Today I'll share a look into our overall process of designing the device and key lessons that we learned along the way. First, to frame up some context around the device, Teladoc Health offers a weight management program, and the device is situated as part of a welcome kit that members receive for free, alongside other in-app tools like goal-setting features, a food logger, relevant data tracking, and access to expert coaches. This project wasn't entirely 0 to 1, as we did have a previous weight scale device that was being sunset. However, that was a pretty standard weight scale, so it really only brought weight data into our experience, whereas this smart device has some expanded capabilities which we were introducing. It is able to capture beyond just weight. It's able to capture body fat percentage and muscle mass data using a technology called bioimpedance analysis. You might be wondering why it took us a month for the device project. This was largely because of the length of time it takes to get FDA approval. And front-loading the device work also allowed us to get ahead on all of the product side work that we needed to deliver. Now, what role does the device itself play? So when a member steps on the scale, the device feeds weight and body composition data directly into the app, and that data is then used to help members track their progress over time toward their weight loss goals. The goal of the product here is to, at a foundational level, ensure that your data comes through seamlessly and quickly and without issue, and then that opens the door really for what we consider the magic. So once a member starts engaging with their scale enough, and the data starts coming through in more consistent patterns, it really opens the door for the product to deliver in terms of personalized insights and behavioral or habit building tools, such that a member is really incentivized to keep going with the healthy choices that they make and really start to compound their progress such that they're able to make a significant stride toward their weight loss goals. From the jump, my team started to form design recommendations and really a point of view about what the scale needed to be and aspects it needed to deliver on. So beyond being reliable and consistently usable, we wanted to open the door toward driving some of that behavior change and being engaging. So one of the things that we delivered in order to provide novelty over time, for example, is that at the end of every weigh-in, there is a farewell screen, and that content, our content team did an excellent job of delivering a dynamic farewell screen so that a member never sees the same goodbye screen again and again, and rather it's fluctuating such that it can provide a desire to come back and weigh in again, just to see what the message is going to tell you the next time you weigh in. Part of this too is understanding that the device is part of a larger cohesive ecosystem, so we needed it to be complementary with the rest of the product experience and all of the rest of the product magic to take place. Now, getting into some of the validation that we did, we worked really closely with our user research team to determine what all we needed to test, and even with just a month time frame, we were able to do multiple rounds of testing. Now, with a month, you have the restriction of needing to work really fast and being creative. One of the things I'm really proud of my team for is that we came up with a way to do a quick, unmoderated research round, even without the ability to send all of our participants a test prototype of the scale itself. So the team replicated the size of the screen on the scale on the mobile phone Figma prototypes, and we were able to essentially run an unmoderated round of testing where we prompted people to put their phones on the ground and imagine that it was a scale. And this enabled us to really validate the design approach and refine it along the way based on what we were learning in terms of what was resonating with people. And this largely helped us move toward a UI that we could recommend more confidently. Now, this in-person testing round we did. So one note about medical devices is that usability is truly a non-negotiable. The FDA currently rejects 90% of device submissions year over year simply on the basis that they're not convinced that the devices have good enough usability. So in our in-person rounds, we gained feedback on a lot of aspects of the scale experience, everything from the packaging and unpacking the scale through to the speed of the screens, the sequence, and the comprehension of body composition. And I remember this round happened largely after we had handed off the first draft of screens to the software partner, and one of the things that we prioritized updating from findings of this round was that it takes a little bit clear guidance to members in this new device that for people who don't have the mental model of a smart scale and only have the previous mental model of a standard scale, they think that you could just step on and step off pretty quickly when the device actually requires you to stay on the scale for 2 to 3 seconds longer in order to run that expanded analysis of your body composition. So one of the things we prioritized was in the updates that we did over the air was to more clearly state to stay on the scale for body composition as the loading screen displays while it's running. Then just to give a look into some of the previous versions that we had explored before landing on the final design of the body composition metric. Ultimately, we were playing with this idea of how much context to provide on the screen. Note that these screens really only last 3 seconds before it flashes to the next one. And in the balance, we knew it was important to convey the range that our clinical team had recommended. And one thing about the range is it would vary depending on the age, gender, and height of the members. So depending on those factors, our clinically recommended healthy range for body fat is going to be a little bit different based on each member. And that aspect of it made us really think about whether we wanted to just simply convey a binary you are in range or out of range, or ultimately where we ended up leading was showing you where you fall in relation to that range. And importantly, we wanted to be cautious of conveying any kind of criticality status related with being over the recommended body fat percentage, as that itself was a criteria to join the program. You had to be of a certain obesity percentage to be here. So how the question we had to ask ourselves was how to lead with empathy when it comes to not making someone feel that they are in a red zone or a problematic zone. And that, just to give you an idea of like some of the balance that my team had to strike here. Now for the final winning design, we were prioritizing scannability. So one of the things we did was simplify back, not showing more copy for this screen, and really just letting the app do the work of needing to interpret and analyze your data in depth. So for this, really just showing where you fall with that caret in relation to the green healthy range. And this screen here shows someone who falls above it. So again, we're ensuring kind of an empathetic approach here by not showing any element of alert or urgency, criticality, stress, anything that the member could perceive as stress for falling above the healthy range, while leaving it scannable enough to just be 3 seconds long, and driving interest to go to the app to engage with your data and understand it a bit more. Just to show quickly what it looks like if you fall within the clinical range, it's the same kind of concept. So the caret would move based on where you land. So not in any particular order, but just to showcase some of the other data displays that my team delivered. This is your standard weight screen. Then I wanted to showcase the only trend that we display on the screen, on the scale itself, is a simple weight trend line. And this was very intentional in the sense that we want to leave most of the trends and actual in-depth data and interacting with charts in the app itself. However, we also do a lot of work in our program, in our weight management lessons and surrounding assets, to tell members to not get discouraged based on the number that they read on their scale. So especially any one weigh-in. So we try to educate members that factors like dehydration and menstruation alone can drive a 10 to 12 pound difference in any single one weigh-in. So part of what the program really tries to emphasize is that your average, or where you're trending, is more important than any single one weigh-in. For some of the takeaways we had, so weight loss is known to be a difficult journey, and many people who have struggled with it have tried multiple programs and multiple solutions in the past. And oftentimes the practice of stepping onto a scale can be a very triggering experience that takes work to combat. We also found that people did feel an aspect of regained control and motivation once they saw their body fat percentage and learned that they could track that discreetly from the blanket weight metric. It really opened the door for them to feel positively about interacting with this specific device and their program. We learned that people are more likely to succeed when they feel encouraged and empowered by their program, and generally when they feel that they're doing a good job with their healthy routine, they are much more likely to engage. Moving now to the product side. So my team was also responsible for designing how the app onboards a member to the scale, and really everything from that initial connectivity flow through to all of the data displays. So this really just showcases that from the very first level, where we're telling you that there's a body composition mode you can turn on, we're also educating you that that includes body fat percentage and muscle mass, and we're providing supplemental assets as you go forth to learn more about how tracking these metrics can add and improve your overall weight loss journey. The data displays themselves, to get into this a little bit, the main thing we wanted to deliver on is simplicity and scannability. So this data snapshot preview, it would be shown alongside other snapshot data cards, health data cards. Depending on what the member has access to, they might see different metrics than another member, but this would be shown just as weight would be shown right next to it. We decided to deliver a dual metric card for the first time, since these metrics of body fat and muscle mass have a relation between them, such that when a member loses some body fat, it is known that they're going to be increasing their muscle. So these are directly correlated, and that informed our decision to group those into one data card as opposed to having separate ones. The empathetic approach that we are trying to champion is also shown here, in that we will have a status tag for once you've reached the healthy range, but we won't show an alert telling you that you are out of range when you are out of range, because a member would see that right away, and it would drive kind of a negative connotation that could be stigmatizing based on what we know of our members. Great. So that was the project. Let me know if you have any questions, and thank you for having me. You can reach out on LinkedIn. Bye, everyone.
Hello there, I'm Cezar Bianchi, UX Visual Designer at GE HealthCare, working on the Ethos Design System team. Today, I want to talk about something I call the life-saving pixel, reducing clinical cognitive overload through visual standardization. Let me start with a moment. Picture an ICU at 2 a.m. The lights are dim, alarms are going off, and there is constant movement. A clinician is moving between a patient monitor, an AGR system, and a device interface. 3 screens, 3 different visual languages, all competing for attention. And here in this slide, you can actually see that kind of environment. Multiple devices, multiple signals, all active at the same time, when every second counts. That is not branding. That is the reality clinicians operate in every day. In that moment, the interface either amplifies the stress or absorbs it. What I want to show today is how design, very specifically visual consistency, can reduce that stress and become a kind of safety net for clinical decision making. Cognitive overload is a patient safety risk. As we move forward, it's important to ground this in research. We know that when interfaces force clinicians to search for information, cognitive workload increases, and with that, the likelihood of errors increase as well. In this slide, you see a clear summary of that dynamic. Poorly designed interfaces don't just slow people down, they actively contribute to clinical risk. At the same time, when visualization surfaces patterns instead of forcing users to search, the workload drops significantly. And then there's the environment itself. Healthcare settings amplify everything. There's high data density, constant interruptions, and something we hear often, alarm fatigue. All of these stack together. So the key takeaway here is simple but critical. Cognitive overload is not just a UX problem, it's a patient safety issue. A single UI, many clinical contexts. Now, let's look at what makes this even more complex. A clinician doesn't interact with just one interface. Over the course of a single shift, they move across bedside monitors, tablets, desktop systems, and large shared displays. Here in this slide, you can see a clinician interacting directly with a touch-based device. And that's just one moment in a much larger workflow. What changes constantly is the context. Screen size changes. Input changes from touch to mouse to keyboard, sometimes even through gloves. Lights condition shift from low-light ICU environments to bright operating rooms. But here's the challenge. The clinician doesn't have time to relearn each system. So the goal is not to create one rigid interface. The goal is to create one recognizable visual language that adapts to all of these contexts while remaining familiar. That's what reduces friction. What research says? When you look at research, one pattern emerges very clearly. Visualization changes everything. In this slide, you can see a dashboard bringing together multiple data streams into one unified view. Instead of bouncing between systems, the clinician can observe trends, relationships, and changes directly. The important idea here is that dashboards reduce time, reduce errors, and significantly improve situational awareness. Because ultimately, clinicians are not just reading values, they are trying to understand stories. Is a patient stabilizing? Is something trending in the wrong direction? Without visualization, that story has to be restructured mentally. With visualization, the systems tell the story up front. That's the shift from searching to seeing. Designing for zero mistakes with component libraries. Now, once we surface information effectively, the next step is making interaction predictable. Here, in this slide, you can see multiple interfaces that share the same underlying pattern. Even though they exist in different products, they behave in the same way, and that's the key. Under stress, clinicians don't explore interfaces, they rely on habit. They expect a button to behave the same way every time. They expect feedback to be consistent. They expect interactions to follow a pattern. Pattern libraries help enforce that consistency. They create systems where states, transitions, and behaviors are not up for interpretation. So instead of asking the user to adapt to the interface, we make the interface adapt to the user expectations. And that's how we begin to design for fewer errors. From data to decisions. Now, even with consistent interaction, we still have to tackle the complexity of the data itself. Because the issue in healthcare isn't that there's too much data, it's that it takes too much effort to understand it. In this slide, you can see how structured and consistent layouts highlights what actually matter, When hierarchy is clear, change becomes visible. Priority becomes obvious. Without hierarchy, everything looks equally important. With hierarchy, the interface begins to guide attention. It answers the questions of a clinician is asking subconsciously. What changed? What matters? What do I need to act on? And that's the moment where data becomes decision. Bridging physical and digital, a unified visual language for devices and software. Now, let's zoom out and think about the system as a whole. In this slide, you see a physical medical device interface. And what's important here is not just the device, it's the continuity. The same visual rules apply across devices, applications, and platforms. Ethos aligns everything through shared foundations, tokens, interaction states, icon systems, and motion. So whether a clinician is using a bedside monitor or a cloud application, the experience feels connected. And that's important because clinicians don't think in terms of systems or platforms. They experience one continuous workflow. The less transitions they have to do, the faster they can act. Governing a design system across a global health tech enterprise. When you bring this approach to enterprise level, the impact grows significantly. This slide shows different clinical contexts, different environments, different use cases, but all aligned through a shared system. Instead of teams building solutions independently, they reuse components that are already tested, validated, and aligned with regulations. That reduces duplication, reduces risk, and speeds up delivery. And in healthcare, where systems operate under strict constraints, that kind of alignment is essential. It allows design to scale without losing quality or consistency. So what makes Ethos clinical grade? At this point, the design system becomes more than a design tool. It becomes infrastructure. In this slide, you can see what makes Ethos clinical grade. Color is not static, it's semantic, it carries meaning. Dark and light modes adapt to environment conditions. Interaction states are standardized to support both accessibility and speed. Typography ensures legibility across distances and devices. And localization supports global use. All of these pieces work together so that design intent translates directly into code without ambiguity. That consistency is what makes the system reliable in real-world clinical use. Trust by design, micro-interactions, color, and radius. Now we move into something more subtle, but equally important. Trust is built in very small moments. In this slide, you can see how micro-interactions, color roles, and even spacing decisions affect perception. A subtle animation confirming an action removes doubt. A consistent color tied to severity communicates urgency instantly. Spacing and density determines how quickly something can be read. These are small things, but they shape confidence. And in high stakes environments, confidence is critical, because hesitation often comes from uncertainty. Standardized clarity. When you scale those principles, you get consistency across the entire system. In this slide, you can see interfaces spanning multiple devices, but maintaining the same structure. That consistency makes information immediately scannable. It eliminates the pause where a clinician might otherwise ask, "Am I reading this correctly?" Instead, the interface becomes predictable, and that predictability reduces hesitation and supports faster, more confident decision making. System impact. At this stage, we begin to see measurable impact. Design systems like Ethos don't just improve usability, they accelerate development. Teams can move faster because they are using shared components. At the same time, accessibility and internationalization are built in from the start. And importantly, Design aligns directly with enterprise strategy. It's no longer a layer added at the end. It's part of the foundation. From pixels to patient safety. Now this slide brings everything together. When we standardize components and visualization patterns, we reduce cognitive load. When we design for real environments, we improve usability in context. When unify physical and digital, we remove translation effort. And when we govern the system properly, we ensure it evolves and improves over time. A design system is not static, it's a product. It requires measurement, iteration, and continuous alignment. And ultimately, all of this connects back to patient safety. And that brings us here. Our intention is simple: help clinicians see clearly, decide faster, and care better. That statement may sound simple, but achieving it requires thousands of small, intentional decisions. The idea of the life-saving pixel is not metaphorical. It represents all of those decisions working together: color, spacing, interactions, hierarchy, each one reducing friction, each one reducing clarity, supporting clarity. When design is done right, it becomes almost invisible, but its impact is very real. It shows up in faster decision, it shows up in reduced errors, and ultimately it shows up in better patient care. I invite you to explore the Ethos design system and see how these principles come to life. Thank you.
Hi everyone, hope you're doing well. So today we're going to talk about patient data and their attack. So I want to learn you some Pentest lessons for health tech designers. My name is Victoria. I'm a certified security engineer and penetration tester at TechMagic. Also, I'm AWS community builder. I like to break in apps, of course, legally, to make them safer. It's how ethical hacking works. I have background in web, AI, cloud, mobile, and network security. Currently, I'm focused on not leaking patient data. And some additions, like I'm a CTF player, musician, coffee addicted, so maybe we have something in common. Let's start with patient data, why we're talking about it today and why it's not just a regular data. Because hospitals, like a lot of fintech companies or military tech, have a big amount of sensitive information, like medical history, mental health, identity data, and insurer and financial info. It's why it's important, because it's something which really can cause some reputation, financial data loss, and it's information which is turning in hospitals, and it's why so many compliance exists. So you already heard about HIPAA if we're talking about hospitals, but as well you can find about PCI DSS or something else. So when the infrastructure or product is working with sensitive data like financial or health one, it always needs to be covered by compliance. And of course, compliance includes big amount of security questions and security rules which need to be covered in them. So what pen testing actually reveals? Vulnerability is not like complex technical bugs or something like that. Reality that most issues come from bad flows, weak assumptions, and sorry about UX shortcuts. So it's not very deep. It's not always very deep or complex stuff. It just really can be covered by design or some misconfigurations. So let's talk about them. Top 5 pentest fails I see every time. Of course, it's broken access control. IDOR is everywhere. I will cover it in the next slides. Weak or fake identity verification. So, of course, this is what everyone tried to use to bypass these authentication flows. Trust in the front end. Other side, trust in the UI UX. Insecure account recovery flows, because, of course, we have them, but they can be set it up not very securely. And the privacy by default exposed. I want to share my opinion by covering 4 scenarios today. So the first one is about insecure onboarding. On each scenario, you will see this QR code with a real attack example. So you can scan it and read about attack more deeply. So to understand that it's a problem, not like Victoria is talking or imagining it from her perspective. So it's already was. And common issues is like weak identity verification when we trust user by default, predictable IDs when they are very easy, even if they're not very easy, but you have no rate limiting. So for example, you have, I don't know, 16 numbers or 16 letter and numbers without rate limiting. As a hacker, I can see that it's 16 symbols and try to force it like random symbols and numbers. Yes, it won't be so effective like +1, +2, but still, it may have more time, but can predict and guess some of IDs. So rate limiting is very important step here, and account linking flows. So let's go through the attack scheme. For example, we have a user sign up with a weak identity verification. So like account will be created and linked to the patient profile. The question here, is the patient ID verified? If yes, we will grant the secure access. If no, so attacker can enumerate patient ID. So just try to brute force, or again, if they're easy to guess, just by guessing which account is the next. Link victim patient ID and access to the victim record. So it's very easy attack, which was done before some compliances was covered in this topic. And design lesson. So onboarding is our security boundary. It's why everything needs to be covered here. And you don't need to optimize for this fast sign up. You know, we always have this discussion between designers and security engineers. Like security engineers want to do everything very secure and very hard, but designers, as a part of user experience, want to do everything simpler for users. And so here I want to add, if we're talking about sensitive information like hospital, a financial organization, you need to add more security here. So of course, fast sign up is cool stuff. If we're talking about some, I don't know, website with news or something not very important, but if you're talking about sensitive data, please, you need to think securely here and make sign up more secure with additional step, with maybe two-factor authentication here, but not just fast and simple. If identity proof is weak, everything after is broken. Why? Because we are already access the system and can manipulate everything further. Also, the second thing is like if identity proof is weak, you need to understand that everything inside will be even more weaker. Scenario number 2 is broken access control. It's one of the most critical issues in web applications, and here as well you can see the QR codes. So let's go through some common issues. It's like IDOR, insecure direct object reference, when you can change the number, change the ID and access this file. Role confusion, so we have doctor with high privileges like administrator, for example, and patient who can be like just read only or at least privileges as possible. And missing some authorization checks. So when you're inside the system, you already trust it, and without additional checks on other data, other functions, or something like that. So again, here we have a scenario. For example, user logs in and requests the patient record. And from 10 cents request with patient ID in this request, for example, like, I don't know, financial information of this user by this ID. So if we have this authorization check, access denied or filtered, for example, but if we have no this check, direct object access will be allowed. So we just can click this ID and access what is inside it, or maybe it can be some additional functions like edit ones which must not be allowed or not allowed from the UI side. Attacker also modifies this patient ID and can access other patient records. So, for example, have other requests with this user ID, or as well enumerate this ID to access information of other users. why it happens. So we have front end assumes backend enforced rules. Front end is like UI, and backend trust front end. So when we have restrictions or some security rules only from UI side, when you have restriction or disallowed button to edit information or something like that, and backend just don't have this rechecked, and it's why we also it's a common situation when we have this backend when we need to add some backend verification as well, and don't trust everything which will be done from the front end side. When we are talking about design lessons, I want to cover roles and permissions. So they must be explicit, enforced everywhere, so not only by accessing the system or accessing some information. This ID and other ID tokens and other information must be enforced everywhere, just quite everywhere, not just in one place checked once checked and that's all. And tested as user journeys. I think designers not know what we're talking here about. And if your system trusts the client, it trusts the attacker. So it doesn't matter who will be inside. For example, sometimes hospitals build this like trust boundaries. You don't have self-registration or something like that. And it's why you trust everyone who is inside the system. So it's not matter client, it's or intruder or something like that. If you trust the user, you trust the hackers as well, because attackers will be clients, users, or everything else. Scenario number 3, your question, human factor exploits. I want to share examples like phishing via appointment emails, for example. So when we're talking about phishing, it's very important to add social engineering here. When we know that person have some appointment in this clinic or something as well, which can be used in future emails, like to cover something which what this user client will trust. And of course, password reuse, when we have some stuff like you use the same password in a different system, and your for hospital can be or other system can be secure enough, but the password was leaked from other system. When password is leaked, it's already used in this list which are available for brute force, or even if it was leaked with your mail or username. Of course, username will be checked in other system to try to find it and to reuse this password. So even if hospital was secure and all policies was secure, you need to understand this password leakage possibility, which can be brute forces in future because of leakage from other products. For example, attacker initiates contact, calls support, sends an email, and claims urgent issue. If you're talking about social engineering, it's always this quite stuff when trying to urgency or very important stuff in small amount of time. And like I can't access my test results and try to cover it. I have bad connection. I need it as soon as possible. So use some social engineering techniques just to try to bypass some security thoughts of this here technical stuff. So if support follows strict verification, in most cases requests will be denied because not covering all security stuff. But if no support bypass verification, account access will be granted or resetted. Like for example, forgot password and need to access it just in 2 minutes, and this technical support won't instead thinking will miss some important steps, and is how attackers gains control of account and access patient data. Design lesson: security is not just technical stuff. It's also about some social engineering, psychological stuff, and something about this. And the flows must assume confusion, stress, or urgency. So you need to design systems relying on these points as well. So how it can be covered if a patient or is under the stress, or there is quite urgent situation or something like that. And so it's why if human can bypass something, attackers exactly will. And the latest scenario today, like privacy dark patterns. Examples: after sharing data by default, unclear consent, misleading toggles, hidden privacy settings. So it's quite the same stuff when sometimes something is unclear. You can't understand what this toggle meanings, or is it disturb you? It's secure or not secure, something unclear to you or misleading. So you just toggles broke the logic of the security moments, or some privacy settings which are hidden and can't be set it up by users even if they want it. Problem: users don't understand exposure. In most cases, of course, if we're talking about hospitals, people trusting by default. They try to rely on hospital security as itself, so not even trying to do something by themselves. Of course, again, we have people who are not very deep or familiar with such questions, and they just log in because they need to. They don't think about it deeper. And designers optimize engagement it's more important than safety. It's also a problem when we design such things. Let's go. Users sign up to the application and presented with privacy options. So the question: are settings clear and honest? If yes, so informed consent is given. User control data sharing, or what can he or she do by secure him or herself? And if no, if we have some confusing UI, some misleading toggles, default, it's data sharing enabled when we share some information, maybe not so secure and sensitive as compliance already covered, but some others people don't want to share. User unaware of exposure and data shared with third parties or other users. So it's sensitive patient data was exposed, and even if it was a problem of patient, you as a clinic, as a hospital, will have this reputation and financial losses, because really big amounts of such questions must be covered by the compliances, or the problem by design also will be added to this attack, and in most cases rely on the company, on the hospital itself, not on the client. So design lesson is transparency, it's a security control. Everything must be clear. Consent must be informed, clear, and reversible. So everything must be very easy to understand and to set up. And of course, confusing UX is a vulnerability. Sometimes people want to think about secure, but some messages, some logic just confuse them, and then they cannot to set up it properly. And let's move on. Root causes across all the attacks. Patterns we keep seeing: it's over trusting the user as a client. For example, it's just a user, what they can do, or they are already inside the system without self-registration, so everything next is impossible. Optimizing for speed over safety, or optimizing for some business features, which is very popular now. So first of all, we need to do business features, then think about security. In some products, it can work. I don't like it, but it can work. If we're talking about sensitive information like HealthCare, no, please, no. Missing edge cases in flows, or not threat modeling during the design is something I really like to talk about threat modeling. When before designing the system or during the design, you try to build the model of possible threats. So it's why when you think like a hacker, you can do it like a team building, for example, or something like that, and brainstorming any common thread. So anything you think the hacker can done, if it's impossible, you need to say it, and then to think how to secure over this attack, how to be secure over this attack. And the security added too late. Some people will say that it's never too late, but I think you will agree that when you have this financial and reputation losses, it's quite late to add the security. So please do it before productions and even before building system, but during the design. And let's move on. What designers can do, frankly, really a lot. So design for abuse cases. If we're talking about threat model, when you're asking some possible questions, what can it's like some of examples. So ask, how can this be misused. So don't think that patient won't do it, so they don't know it. Just ask you, how can it be misused? Make security visible. So make this clear states, clear permissions, clear ownership of data, because as we already discussed, when something is unclear, it can be misused. Reduce implicit trust. So never rely on UI only restrictions. You can have this UI only or client side as you want restriction for some fields from some file uploads or something like that. And don't make your server trust about this restriction. In my hacker world, we just catch this request and try to manipulate file types, manipulate this data and do it over the proxy. So when server has no additional checks, we always will bypass it. It's very easy attack and really a common one. Please protect critical flows. It's what you need to start with. It's, of course, some critical data, critical flows, which have the sensitive information like onboarding, account recovery, and data sharing. So everything which have this sensitive info. And design for human under stress where it possible. So add this simple verification, not without security checks, but to make it more simpler and not like you're logging into the Pentagon. So, and no shortcuts for sensitive action. So you already saw it in most cases, maybe in banking apps or something like that. So you're already in the system, you're doing something, you're watching something, but when you need to change something critical or to pay for something or something very, again, very critical, you will be asked again for the password or for some code from your phone. So to be asked for additional authentication to proceed with this function. So think deeply about these actions and no shorten them. You better to make them more complex, but still simple. And what we see before and after secure design. So before, it's like typical product thinking. We optimize for speed and conversion, minimal friction onboarding, trust client-side logic, add security later after business function or everything else, and hide complexity from user. So we make it easy, fast, and that's all. After, secure by design thinking. So design for abuse casing, think about them prior designing. Strong identity from day one, so not after production release, from day one. You need to add this. Zero trust between components. So sometimes we build this trust boundaries, like everything what's inside the system we already trust it. Again, for a good example, it's self-registration. So not self-registration is allowed. What means that who is inside the system, we already believe them and their action. No, zero trust between all the components. And also not only between, like we have administrator and not administrator. So you need to build it on each component, each part of the application. And security is a part of user experience. Really, it's really important, and edit it when you design a system, not after. And also, good thing is to make risks visible to users. Some like adding error messages or something. Some alerts, for example. So make user understand which data can't be exposed, which data they need to hide, which data they don't need to share, and so make people understand about security as well. So make this risk be available to users for their understanding. And practical principles, so identity is everything. Every object needs authorization, not like if a user logins to the system, we have this authorization token and that's all. Authorization needed to get every object, to get to do every function or every request. Assume the client is hostile. Clarity reduce risks, of course, as we already covered. Security must survive human error, and design decisions must be security decisions. So it's not like it's common thing to think. So security is a shared responsibility, really. So when you think that security must be covered by security engineers, it's falls from the first steps. It's not true. Security really a shared responsibility. When everyone will think about it, designers, developers, DevOps, QA, so the system will be really secured. Trust me. And here are some checklists. So first of all, identity and access. Do we really verify user identity? Can user access only their own data? It's a question you need to re-ask and recheck and retry to system design. If we're talking about critical flows, is account recovery secure? Or maybe, I don't know, email can be received by new user mail, not the old one. Or the issue we see recently. So recently it was like, this 2FA code, which received the user to log into the system. And this code was applicable to other users as well. So it was not unique. And when I tried to log in with other users' account, I just tried this code, which I received with my user, for example, or something like that. Are sensitive actions re-authenticated? It was checked how long session is. Maybe, login was 3 hours ago and only now is trying to do something. Or like, again, this two-factor authentication code sends them with this action. You need to have this abuse thinking. How can this feature be misused? What happens if someone skips steps or something like that? So threat modeling here is very nice one. User experience and privacy. Are privacy setting clear? It's the part when we was talking about toggles or some additional error messages or some information with these settings, and are defaults safe? So we always recommend to follow the principle of least privileges. So when you allow only small amount of needed things, and maybe you already heard it about this whitelisting or blacklisting, and it's always a bad idea to use blacklist. So when you want to restrict something, you always and always and always will edit. Some functionality can be changed or something can be missed. So it's a problem, and it's why we don't recommend it. Well, we recommend whitelisting. So whitelisting plus least privileges principle. So when you allow only few things you need to allow. If you need to allow something more, you just add it to this list, and it's easier to manipulate. It's easier to check it regularly, and it's why we like this step. And if we're talking about also defaults, remember about compliances. In most cases, compliances like closed most of these gaps, and it's a good point when system by default is closed and it's available to open some or share some information if user wants it and if compliance allows you. But better by default close all this stuff to make people who don't think about it or not familiar with it be safe. And architecture, so does backend enforce all rules? Does it check or trust frontend by default? And do we assume the client is hostile? I want to finish with special phrase here, but I can't choose one. So it's why three of them here are applied. We don't secure system after they are built. Please, it's really big problem when you already have some corruptions, when you already have some financial or reputation loss. It's even security won't fix it after some leakage, and sometimes it's really not available by by development. So sometimes some functions already was applied by the way, which can't be fixed and make more secure now, and you need to make it other ways and more complex and harder. We design systems that are hard to break. So again, design them, do it prior. We have some leakage or attack. So on every step from the first one, on every design function and moment and component, they need to be secure and hard to break. And please protect passion by design, not by patch. Sometimes it can be really late. And I want to thank you for attention and to finish with this resources page to go deeper, to understand some security moments deeper. So some links can be found by this QR code, which can allow you to understand more about security, about some common issues, about some compliances checks, and how to build secure hospitals and health tech systems by design. So I really appreciate if you will go through and learn something new for you. And thanks again for your attention. See ya.
Imagine a younger version of me. I mean, just try to picture me without a beard and a better hairstyle. That version of me joined a US healthcare company thinking he was about to design the perfect patient app. I mean, you know the kind, clean screens, calm colors, pretty onboarding screens, the sort of healthcare UX we admire and dribble. And then reality hit. Hi everyone, I'm Sagar. I'm a lead product designer at Innovaccer, where I work on a care management product called Atlas. I am currently based in Abu Dhabi. I moved there about 3 years ago from India, and over the last 5 years, working on care management has completely reshaped how I think about healthcare UX. It made me realize that some of the most important design work in this space isn't patient facing at all. It lives in complex internal systems, dense workflows, and high stakes decisions. So today, I'm going to talk about that invisible side. Not the patient app, not the idealized journey, but the systems, people, and trade offs that quietly shape patient outcomes. And I'm going to do that through the lens of care managers. Like any product designer, I call myself a problem solver, but care managers are the real problem solvers. I'll start off by setting some context. If you're not familiar with the US healthcare system, care management exists because healthcare is fragmented. Patients, especially high risk ones, they don't just need treatment, they need coordination. Let me give you a simple example. A patient, let's say, gets discharged from the hospital after a heart procedure. Now they go home with new medications, discharge summary, new dietary restrictions, follow-up appointments they need to book. But if nobody checks in on that patient, like if did they pick up those prescriptions, do they understand those dosages, do they even have a way to get to those follow-up appointments? That patient is at risk of ending right back into the emergency room. And that readmission is expensive. It's stressful for the patient and their family, and in most cases could have been avoided. Now that's where care management comes in. It's the critical bridge between the patient, the provider, the hospital, and all the invisible follow-up work that keeps care on track. Its purpose in the simplest term is to ensure that patient doesn't fall through the cracks after leaving the hospital. Now, here's what most people don't realize. Healthcare UX is not just about designing for patients. A lot of healthcare is powered by people coordinating care. And when we design for them, you're not just designing an internal tool. You're designing something that can indirectly influence whether a patient gets the right support at the right time. Over the last 5 years, I've run into realities that challenge a lot of what I thought I knew about UX. I mean, even if you never designed for healthcare, I think these will resonate because they are really about what happens when your users are multitasking, your systems are messy, your stakeholders disagree, and the textbook's UX strategy just stops working. Three realities I wish someone had told me before I started at Innovaccer. Now you might be wondering, who are these people doing this coordination? Let me tell you about them. Care managers are not just users sitting at a desk clicking through a system. They hear patient problems from 9 to 5, missed follow-ups, gaps in care, medication confusion, even social barriers. And yet they show up every day and get things done. They are generally measured middle to senior aged people. Most of them have been in healthcare for years and they are incredibly skilled at their job. But they are not tech savvy. Technology is a tool they use, it's not something they grew up with. I mean, I remember we noticed a care manager during a user shadowing session literally dragged the scroll bar. I mean, they literally grabbed the scroll bar with their mouse to scroll through a form. That moment stayed with us. Not because it was wrong, but because it told us something about who I was actually designing for. But there's another layer to this. Care managers aren't only your users. In care management, you are never really designing for one persona. In product design, we usually like to say know your users, focus on the primary persona, optimize for their goals. Great advice. But in care management, one product has to work across multiple personas with very different goals. The care manager needs immediate actionability, like what do I need to do with the patient right now? What has changed? What's urgent? Whereas supervisors want oversight and outcomes, like how many patients were contacted, how are we performing against the targets, who on the team needs me the most. Meanwhile, our secondary users want their specific slice of context. A pharmacist needs the medication history, a social worker needs to know if the patient has transportation or housing issues. And then there's the patient. Now, they might never touch the screen. They are the person who are most affected by what happens inside it. So, one workflow might be used, reviewed, and influenced by several people, each with a different need, each with a different definition of success. And all of that has to coexist in one product. I had to find a middle ground, a way to structure the same product so I could serve all of them without failing any of them. One thing we introduced because of this was an AI-generated timeline summary, a crisp overview of the patient's care journey before anyone makes an outreach call, whether that's a care manager, a pharmacist, or a social worker. The reason was simple. They don't always have the time to piece the story together from 10 different places. They need quick context. Like, what has happened so far? What changed? Why does this patient need my attention now? In healthcare, you are not designing screens, you are designing shared understanding across multiple people. And that's a very different problem than building a single clean persona interface. Second reality really got me off guard. To understand it, you need to understand what care managers use every single day before they even open our product. They use EHRs, electronic health records like Epic, Cerner, Athena. Here are some screens to paint the picture for you. As you can see, they have tiny fonts, overwhelming amount of information crammed into a single screen, workflows that force you to memorize where things are rather than discovering them intuitively, interfaces that look like they were designed in the early 2000s. Well, most of them actually were. EHRs aren't niche tools. They are the backbone of US healthcare. Clinicians spend more hours in them every day than they spend even with their own patients. These companies have been around for decades. They have had billions in investment and they dominate the market. And yet, clinician burnout tied to EHR usability is a well-documented crisis. The UX has barely evolved, and that's the environment our users come from. As designers, we are taught to simplify, reduce clutter, make it clean and minimal, strip out the unnecessary elements. I mean, that's what good UX looks like. So when I first started designing, I walked in with a lot of confidence. I thought, of course, that cleaner pattern will well. Of course, users will prefer a modern interface or what they have been stuck with for years. And then we started getting poor user feedback. When we actually dug into the reason, the picture was more complicated than I expected. It wasn't because our product looked bad or felt broken. It was actually two things happening at once. First, our workflows were different from how things functioned in the EHRs. Users expected things to behave in a certain way, the way their EHR did it. And when our product didn't match it, it felt wrong to them. Now, these are people who learn technology on their job. They were trained to interact in very specific ways. Their habits, their muscle memories, their comfort zone, all was built right there. Second, we were actually too aggressive with simplification because a care manager is often doing several things at once. On a call with the patient, they're on our system, they have the EHR open, they're even taking notes, they're reviewing reports, and they're trying to decide the next best action in real time. So when we buried important information in the name of visual cleanliness, we weren't making their lives easier. We were making them harder, and in some cases, we were actually increasing the risk. Now that was a humbling moment. And this is where Jacob's law became too real for me. People spend most of their time in other systems, so they expect your system to work the same way. Now that changed how we designed. Instead of trying to replace everything familiar with something cleaner, we started studying what care managers were actually used to and asking where that familiarity actually helped us work faster. For example, in our medication review module, we moved the patient's medication history from a site sheet and made it available upfront, so users could add those medications back from the history to the current list in a single click. Now, that's the kind of shortcut EHR users expect, all the information available upfront. We also worked on making the behavior of discontinued and modified medications more consistent to the EHR because trust in healthcare workflows comes from predictability more than novelty. We also spent a lot of time increasing the data density of the product while still maintaining clarity. We even had to extend our design system to support smaller component variants because the existing system wasn't built for those dense healthcare use cases. Spacings changed, component sizes changed, typography decisions changed, even patterns that were generic in our regular product surfaces weren't enough anymore. We weren't trying to out-design the EHR for the sake of looking modern. We were trying to take things that worked in those environments, the density, the directness, the always visible information, and strip away all the clutter and the pain and give users something that felt familiar enough to trust, but clear enough to actually use well. The third reality is less visible, but it shapes the product in a huge way. Every care manager's time is incredibly valuable. They are managing patient caseloads all day, and pulling them into a research session means pulling them away from actual patient care. So getting time with them is hard. And when you actually get a session with them, you need to be very strategic about it because not every workflow or every feature is relevant to every user. So depending on the feature, we used to work with our internal subject matter experts to identify which users are more likely to care about a specific area and reach out to them. Now, that's already different from how product environments where user access is quite easier. But this is the second layer. Now we all know that lorem ipsum is not the right placeholder. You put realistic information in your designs. And that's what I did. But here's what happened. When SMEs or users reviewed those designs, they got pulled into the clinical accuracy of the content in the mockups. Like, is this specific medication right? Does this data point even make sense clinically? And that's understandable from their perspective. I know where they're coming from. Healthcare is high stakes, people are tuned to accuracy. But from a design perspective, it means you want feedback on the workflow, on the structure, on the concept. And the conversation gets stuck on whether this one specific medication name is even relevant to the patient's conditions mentioned on the screen. Users used to struggle to remember they were looking at a design and not the final product. So what I built was basically a mid-fidelity wrapper on top of our design system. Now, because high fidelity looked too finished, people reacted as if those decisions were already made. But low fidelity had the opposite problem. Users couldn't figure out how this thing would look inside the actual product. Mid fidelity was the perfect middle ground, polished enough to feel real, but rough enough to feel open. And that's the sweet spot where we started getting the right kind of feedback. Broader conversations happened, more focus was on the direction than the details. Later, we used AI to research and generate high quality synthetic data as well. The right medications for the right conditions, realistic lab values, and clinically accurate terminologies. That filled a knowledge gap we as designers had, and it meant reviewers spent less time getting distracted by the obvious fake content and more time reacting to the actual product idea. Sometimes designing for the product is only half the job. The other half is designing the conditions for useful feedback. So those are the three realities. But there's one more thing I want to leave you with. And that's not a reality about design. That's the reality about healthcare itself. Healthcare data is fragmented. It's incomplete, it's delayed, and it lives across EHRs and other systems. Even when the information exists, interoperability is difficult because there are so many systems with so many varying standards. So sometimes what the user sees in one system doesn't fully match with what they see somewhere else. And I mean, that's not something you can fix with a better UI. It's a constraint you'd have to design around. Learning to work within that constraint rather than pretending it doesn't even exist. It's a part of what makes healthcare UX different. And I think that's the thread that runs through everything I've talked about today. Healthcare UX is not about perfect solutions. It's about working within real constraints and still finding ways to make things a little better. I came into this space thinking I knew what good UX was. Clean screens, modern patterns, minimal interfaces. None of that was wrong. But healthcare taught me that good UX depends on who you are designing for, what they're carrying with them, and what's at stake if you get those things wrong. Familiar can matter more than minimal. Density can matter more than minimalism. A work in progress mockup can get you better feedback than a polished one. And some problems aren't even on the screen at all. They're in the data, in the access, in the systems underneath. And this takes humility. And I think design humility is one of the most underrated skills in this space. And that brings me back to care managers. I said it at the start and I'll repeat it again here. I call myself a problem solver, but care managers are the real problem solvers. They are the people juggling multiple stakeholders, incomplete information, emotional conversations, operational demand, and daily pressure. They are doing invisible work that keeps care from falling apart. And if we design for them well, we are not just designing an internal workflow, we are improving the conditions in which better care can happen, even if the patient never sees the interface. So, when we talk about healthcare UX, let's talk about patient experience, but let's also talk about these invisible systems, the internal tools, the coordination layer, and the people behind the scenes. Because this side of healthcare UX we rarely talk about might actually be the side that matters the most. And before I go, a big thank you to UX Time for having me here today and to all the people who have supported me along the journey. I wouldn't be here without you. A big thank you.
Hi everyone. Have you ever tried to use your phone outside in the middle of the day, under a harsh sunlight? You tilt the screen, you squint, you make a shadow with your hand. For 30 seconds, you are a person with low vision, holding a product that was not designed for that moment. I open with that image because it captures how fragile our work really is. My name is Thiago Xikota. I'm a product designer from Brazil. I spent my career in two different worlds, in the public sector products at national scale and fast moving private product teams at global scale. And here's one idea I want you to keep for the next 20 minutes or so. In health tech, the hardest design problem is usually not a screen. It is what happens between screens, between teams, between systems, between decisions. Today, I'll talk about the two words that shaped how I think about the problem. Bridge, the GovTech lab where my daily work and my research collided with two government design systems, one of them built for the world's largest public health network, and Wellhub, where I worked as a product designer on end-to-end journeys at global scale. This is a talk about connective infrastructure, the tissue that holds a healthcare experience together. Let's start with why these journeys break. When we say healthcare experience, we usually picture a patient with an app, but that picture is missing almost everyone. A single healthcare journey passes through many hands. The patient, of course, but also doctors, nurses, and community health workers. Also support teams answering messages, operation peoples managing schedules and facilities, product teams shipping features, compliance teams interpreting regulations, and a stack of internal systems that never appear in any user interview but decide what's even possible. Here's the uncomfortable part. each of these groups sees only a fragment of the journey. The support agent sees the ticket, the designer sees the flow, the engineer sees the service, the compliance software sees the risk. Nobody sees the whole thing. I saw this up close at Laboratório Bridge, a GovTech lab in Brazil. My own product was not in healthcare. It was a national education platform serving about 14 million people. But Bridge also built the system behind SUS, the largest public health network in the world. And my research took me deep inside its design system. Public platforms at that scale share one condition. You design for almost every demographic imaginable. Older users, people with low digital literacy, people with disabilities, often on outdated devices. No single person can hold that full journey in their head. Not the designer, not the product manager, not anyone. So the experience does not live in the screens, it lives on the handoffs. The moment a referral moves from one system to another, the moment a patient contact moves from an app to a human, the moment a design moves from Figma to code. And those moments between things are exactly where healthcare journeys break. So, why do they break there? My answer after years inside these systems is one word: fragmentation. Not bad intentions, not lazy teams, fragmentation. It looks like this: two squads solve the same problem in two different ways because neither knew the other one was solving it. A pattern established in one product, then reinvented slightly different in the next one. A decision is made in a meeting, lives in someone's memory, and quietly dies when that person changes teams. And there is a version of that that designers know intimately. I call it the pixel mirage. We craft a beautiful pixel perfect screen in Figma, contrast checked, auto layout immaculate. We hand it off and we believe we ship that quality. But what we handed off was a picture. The structure underneath, the semantics, the focus order, how component behaves when a screen readers walk through, none of that travels in a picture. The point is, the broken experience downstream is rarely one person's mistake. It is the accumulation of invisible fragmented decisions. Design decision one thing, code shipped another, support explains the third version to the patient. In most industries, that costs you a conversion, but in healthcare, it costs trust and sometimes safety. A confusing flow in an e-commerce checkout loses a sale. A confusing flow in a referral system can lose a diagnosis. So the real design material is not the screen, it's the decision. How decisions get made, recorded, shared, and reused. Which brings me to Bridge. From 2023 to 2024-5, I worked at Laboratório Bridge, a technology lab at the Federal University of Santa Catarina in Brazil, UFSC, Universidade Federal de Santa Catarina. Bridge builds digital products for the public sector. Some teams there build the system behind SUS, the largest healthcare system in the world, which is in Brazil. And my team builds a national education platform serving about 14 million people. And here's the detail that shaped everything. We were required to use DSGov, the federal government's design system from Brazil. We could not change it. It is immutable for teams like ours, and it shipped with serious accessibility problems. So my actual job was not picking colors, it was building the connective tissue around the system I could not touch, mapping failures component by component, specifying fixes with developers in parallel processes, and making sure accessibility survived without breaking a single federal rule. That experience left me with a question. If a design system is conceived with accessibility as a core pillar from day one, does the problem go away? Bridge had built one, Bulge, an open source design system created specifically for the public health platforms that serve SUS. So for my thesis, I audited it. I compared both against DSGov, a component by component in the code. Both won that comparison, and my audit still found 75 accessibility failures hidden in its coded components. One example that stayed with me, a multi-select dropdown intended for a patient's symptoms, visually perfect, but the semantics were never specified at the handoff. It was built from generic div elements, the selected state was never announced, and screen reader users could not tell which symptoms were checked. The checkmark was there, the code was blind to it. That research taught me the central lesson of this talk. The gap between designer's intention and the shipped product is not closed by good intentions, not even by a design system with the right values. It is closed by infrastructure, by making the correct decision the default, and by connecting design decisions to what actually gets built. That is what bridge means to me, not just a place. The discipline of building a connection between complexity on one side and clarity on another, even when you do control all the pieces. After the public sector, I crossed to the opposite world. I worked at Wellhub as a product designer, focused on the evolution to end-to-end journeys at global scale. I contributed to accessibility initiatives there, helping product screens reach WCAG 2.A AA conformance, focus order, semantic structure, and area. Wellhub sits in the well-being space, which shares HealthTech's core property. People arrive carrying their health, their habits, and their anxieties, but operationally, it could not be more different from a university lab serving the public sector. It is fast, global, many squads, many markets, journeys that cross apps, partners, and supports. And that world taught me second half of this talk's argument. In a fast-moving organization, the enemy of consistency is not ignorance, it is speed. When teams ship weekly across many markets, any quality that depends on someone remembering to do the right thing will eventually be skipped. Consistency and accessibility cannot be heroics. They have to be properties of the system, which is why the second piece of connective infrastructure matters so much. A visible home for the language. One place where patterns, decisions, and documentations are published, searchable, and owned. Not a graveyard wiki. A product with users, owners, and adoption you can measure. My rule of thumb after these years is if a team cannot find a decision, the decision does not exist. It will be remade differently by the next team, next quarter. So Bridge gave me the shared language, and the fast-moving world taught me why that language has to be visible and effortless. Two halves of the same job, reducing the distance between what we decided and what people actually do. Now, why does all this plumbing matter so much in health tech specifically? Because in healthcare, the currency is not engagement, it is trust. Think about the emotional state of someone using a health product. They might be anxious about that result, booking an appointment they are afraid of, helping an aging parent navigate the system they do not understand. Design choices that are minor annoyances elsewhere become heavy there. So I want to propose three reframes. First, clarity is a trust feature. Plain language, predictable navigation, honest status messages. When a person always knows where they are and what happens next, they relax. Trust is mostly the absence of surprise. You know? Second, accessibility is a safety feature. Remember, the sunlight story from the beginning, accessibility is not separate audience. It is all of us on our worst moments. And in healthcare, people show up at their worst moment by definition. In my accessibility work on large scale products, I focus on exactly this. WCHD of conformance, focused orders, semantic structure, area, boring words, real safety. Third, consistency reduces cognitive load. When every screen behaves the same way, your users spend zero energy relearning that interface, and all of their energy is on the actual health decision. Inconsistency is a tax in healthcare. It is a tax on the people who can least afford it. None of these three things can be achieved on a screen at a time. They are system properties. They emerge when decisions are connected, published, and repeated. Which is why I keep insisting. The connective layer is not operational housekeeping, it is the product. So, what does that change in our daily work? It means shifting from designing screens to designing an operating model. From is this a good screen to will the next 100 decisions be good even if I'm not in the room? Three practices made the difference in my experience. First, annotate the invisible. Stop handing off pictures and hoping. Mark the focus order on the canvas. That's really important. Write down what the screen reader should announce. Specify the states like loading error, empty. If it is not annotated, it does not exist for the person building it. Second, treat your design system as a behavioral contract, not a sticker sheet. If a component looks right but behaves wrong, the contract is broken. The keyboard navigation, the announcements, the error rendering, that is the component. Bake it into a coded version so nobody has to remember it. And third, make the right way the easy way. This is the most important one. People do not follow documentation, people follow the path of least resistance. So engineer path reveals the check patterns, linterns that catch a missing alt text before the merge, defaults that are accessible out of the box. So a rush team on a deadline still ships something safe. Notice the shift. None of this is a screen. They are behaviors of the team encoded into the workflow. That is what an operating model is. The system that produces the screens rather than screens themselves. Designers are uniquely positioned to design that system because we are all the ones that see the experience horizontally across the silos. But we have to decide that is this invisible work is design work. It is, and in health tech, it might be the highest leverage design work there is. If you want to start this in your own organization, here's the simplest framework I can offer. 5 steps, nothing fancy, all of it learned the hard way. 1. Map the ecosystem. Every actor, every system, every channel, one journey touches. Patients, provider, support, operations, compliance, internal tools. Put it on one page. The first time a team sees the whole map, the room goes quiet. 2. Name the handoffs. Every point where responsibility. 2. Name the handoffs. Every point where responsibility moves between teams and or systems. Give each one a name and an honor. Unnamed handoffs are where experiences die quietly. 3. Standardize repeated decisions. Find the decisions being made over and over, the same dropdown, the same error pattern, the same eligibility rule explained 3 ways. Decide once, encode it, retire the debate. 4. Publish the language, patterns, terms, decisions in one visible place that people can find, search, and challenge. Publish it like a product, not like an archive. You need to make it accessible to everyone. 5. Measure adoption, not page views, adoption. How many teams use the share component instead of forking it? How many new flows pass accessibility checks on the first try? If you do not measure adoption, you are documenting, not operating. Map, name, standardize, publish, measure. You can start step 1 next week with a whiteboard. No budget approval required. Okay, so before the takeaway, some honesty. I have watched versions of this fail, including on my own. So I have 4 lessons for you guys. Lesson 1. A system detached from the real workflows dies quietly. If the design system of or the knowledge hub adds friction to how the teams already work, they will route around it politely and it will become a museum. The system has to live inside the existing workflow and not beside it. Lesson 2. Documentation alone does not create adoption. I used to believe that. If we wrote down clearly enough and intuitive enough, people would follow, but they do not. People adopt what's easier than the alternative and what's their peers visibly see. Adoption is a behavior problem, not a writing problem. Lesson 3, and this is the one I would tattoo somewhere. You have to design the system and the behavior around the system. The reviews, the onboarding, the way contributions get accepted, who answers questions, how disagreements get resolved. The social layer is half of the product. Ship the component library without it, and you shipped half of the product. Lesson 4. Trust is built through repeatability. One great screen earns a compliment. The same pattern behaving identically across 50 screens earns trust. From users, from your own teams, repetition feels boring from the inside. From the outside, repetition is what reliability really looks like. And if you will remember one sentence from this section, make it this one, okay? The system is not what you publish, it is what people repeatedly do. I want to leave you with questions rather than answers, because your ecosystem is not mine. 4 questions that to take back to your team on Monday, okay? First, where does your journey break between teams? Not inside a screen. Between teams. Find the handoff nobody owns. Second, which decisions are your teams repeating manually? The same component restyled, the same rule re-explained, the same accessibility fix applied screen by screen. Each repetition is the system asking to exist. Third, which parts of your product need more trust, not more features? In healthcare, especially, the roadmap pressure is always for more. Sometimes the highest impact quarter is one of where nothing new ships and everything existing becomes consistent. And fourth, what does become safer if it's were standardized? Safer for the user, safer for the patient, safer for the team. Standards are not bureaucracy. It is a domain. Standards are a form of care. If even one of these questions starts an argument in your team, this talk did its job. Let me close where I started. In health tech, the hardest design problem is not the screen. It is everything in between. Between teams, between systems, between a decision and the person who needed to know it. Bridge taught me that clarity at scale is built, not wished for. Wellhub taught me that when journeys span the globe, consistency is a form of care. So here is the line I want you to take home. The future of health tech design is not just better interfaces, it is better connective tissue between people, products, and care. Thank you so much for watching. I'm Thiago Xikota, and I would genuinely love to hear where your journeys break. The QR code takes you to my LinkedIn. Talk soon.